Hello, I'm Stephen Little. I'm a cardiologist here at Houston Methodist DeBakey Heart and Vascular Center. With me today, Dr. Geoffrey Rose. Dr. Rose just gave us an incredible Grand Rounds presentation. So Dr. Rose is Chief of Cardiology at Sangster Heart and Vascular Institute at the Carolinas Healthcare System. And today he's going to talk to us about cardiovascular healthcare reform and the cardiology service line and really just some insight into some sort of the macroeconomics of cardiovascular care. So a couple of questions for you. So you just, from your Grand Rounds, and I do refer anybody to go and see the Grand Rounds on YouTube that we just witnessed, you mentioned the gray tsunami.
Yes.
Tell us a little more about that.
So if you look at the demographic patterns, I think we're all familiar with the baby boomer, issue and the way that wave came to shore, as we say, in 2013, when those who began the baby boom wave in 1948 began to turn 65 and so forth. And that will last for the next 20 plus years. But as we look at the US population beyond that, there's no sort of relief, if you will, in terms of numbers of folks who will be coming on board and entering Medicare's age. So in addition to that, compounding that sort of just actuarial issue is the fact that those above 65, of course, are living longer, right? So I mentioned, what was a rounding error back in 1970 of the population 85 and older, is now a significant part of the population, as we all know, in clinical practice. And, the consumption of resources, et cetera, this is really making the financing of Medicare really challenging as we go forward. An increased number of beneficiaries. Beneficiaries will increase, at least, between 2.5% and 3% per year over the course of the next decade, and then, beyond that, those projections continue.
So you clearly have a mastery and an interest in this area, in sort of health, cardiovascular economics. How did you get into that? What's your story in terms of, was this a desperation issue, or how'd you get there?
I think, it's like many of the things that we do, happened out of circumstance and, sort of administrative responsibilities and obligations. As you go about and you're practicing and you've been around for a little while, people start to come to you and ask you for, programmatic involvement, and congratulations to you on taking on the program directorship. But along those lines, these are the things that sort of, begin to come your way. As we started beginning to look at how we were performing as a team, not as individuals, but as a team, and more importantly, how team ball is, how score is kept. I'll use the passive voice, because we don't control this. Outside agents look in at windows on how we perform. We found that we had some real opportunities in our service line. It was not that we were not providing excellent care, but could we show that to, for lack of a better term, the marketplace, right? Could we show that to patients? Could we show that to those who are paying the insurers? And we found that we had some real deficits in there. And as we, began to peel back the onion and peel back the onion and peel back the onion, we began to learn sort of what those issues were. Some are internal in terms of how we're organized and how we do the work, but a lot is external. I think one of the messages that we've got to, put forward is, I think in medicine we can't portray ourselves as the victims. And too often I've caught that sentiment about, things are beyond our control, whether it's the payer environment or this or that. I think we've got to, begin to find ways as providers and with our administrative partners to be able to develop real solutions for this, because, we all want to provide the best of care, and we simply can't do that unless we have the resources available. And anytime we're wasting resources, those are resources that could and should be applied to providing better care for somebody else. So we have an obligation for it, and we shouldn't have to wait until there are penalties for our not doing it. So I think, long-winded way of saying that those were kind of the factors becoming sort of proximate to the situation, and kind of as you put your toe in the water, then it's a foot and an ankle, and next thing you know, you're neck deep. And I think that's what happened.
Fascinating. Do you get the sense that the systems, the healthcare systems, are ready for this? Because I think from a provider level we have guidelines, we have standards, we have a nice understanding of what we're supposed to achieve when we're with a patient. We all work in different healthcare systems, and there's different market forces in different states and different insurance pools. There's so much heterogeneity from the administrative level. Do you get the sense that there is some sort of standardization of how systems are going to approach this challenge?
It's a great question. I think it's really the pace at which systems will approach this work, because I think that a quote I used in the talk this morning, the future's already here, it's just not evenly distributed, right? There's a reason why care in California is organized a certain way, or Geisinger system, or some of the other markets that, for whatever forces that have driven it towards value-based payments, have moved along those ways. And outcomes are excellent and costs are less and so forth. And if we believe in the power of markets, at some point, that's what will become the norm. Medicine is sort of an interesting market, and as you and I have discussed offline previous times, that the consumer is not in a position of strength, if you will. It's an we talk about information asymmetry. When we're consuming other things in our lives, we can make intelligent decisions. There's lots of resources we can use, and we can choose to do this or not that. Medicine's very different, and if we've got a relationship with a provider or with a healthcare system or even with an insurer, we tend to follow the path that is put out for us, with rare exception. So I think where the change is going to come from, ultimately the market will drive it. If it's coming from a regulatory perspective, it will feel punitive. We will feel put upon, because in many respects we will be. So I think the opportunity is really now at a provider level. And when I say provider level, I'm not just talking about physicians and nurse practitioners and nurses and so forth, but I'm talking about the administrative team as well, right? Because at the end of the day, we're all in this to take care of patients. We chose not to do other things with life. We chose to do this. And we all have an obligation to figure out ways to make care high quality, but reliably excellent, sustainable.
With the changes that you see coming, that many see coming, that you've clarified for many of us, do you think that the fairly unique United States approach with multiple healthcare or multiple insurance vendors is sustainable, or is it inevitable that we'll move to a single payer or a fewer payers? What's your thoughts?
So it's again a great question, and people have looked at this. So very independent of politics, but I'll pick a very conservative organization, the Heritage Foundation. Right? Has a list of what they call the list of economic freedom. You can Google it, and it goes through and it ranks countries based upon what this conservative think tank feels is measures of economic freedom, the ability to control goods and capital, and Hong Kong's number one. Doesn't surprise you. Okay.
Yeah.
Well, if you go through that list, the U.S. is number 17 on that list of economic freedom. Okay, so a lot of other places that are maybe a little more vibrant in terms of the ability to grow, and a lot of the sort of values that many of us have, and what we need for a dynamic economy. Each of those countries, 16 above us, either has single payer, okay, or a private insurance with a mandate. Okay, so Germany, for example, private insurance market. Switzerland, private insurance market, absolute mandate. Because they've all come to the conclusion that what we just said before about the market and the information asymmetry and so forth, it doesn't work like buying a car. Right? And then the issue about insurability, well, of course you can't buy fire insurance when your house is on fire, right? Well, the issue about insurance is really to be making an investment now to protect one against future risk. So these other systems have been able to figure it out. I mean, a statistic that is interesting is if the U.S. since 1980, if the U.S. had spent as much on healthcare per capita as Switzerland, and I think we would all agree care in Switzerland is probably pretty good, we would have no national debt. Zero.
Oh, really?
That's the magnitude of the issue. So we're not talking about stinting on care. We're talking about pulling it to a level, instead of 17, 18%, but 7 to 10%, Germany 11%, right? Other economies have figured this out, and again, it doesn't mean it has to be single payer or the UK system. There are other ways to do it. A private insurance market can work, but there have to be teeth in it. So I think that we're kind of dabbling. Just another thing that I came across recently, which is worth sharing. In 1995, Taiwan, which is also one of these countries very high on the list of economic freedom and so forth, pro-growth and so forth, awful healthcare in 1995, terrible. They actually studied the best systems in the world, and what they say, not so tongue-in-cheek, is they learned what not to do from the United States. Now they have amongst the best healthcare in terms of any metric that you would like to pick, infant mortality, survival, anything you want to pick, and they're delivering at this at I think about 8% of GDP.
Wow.
So the solutions are there. Healthcare in the U.S., if it were a country, would be the 6th largest GDP in the world.
Amazing.
So something that large isn't just going to necessarily fix itself, and there's a lot of investment in the status quo. It's going to be very, very hard to change. And when Don Berwick talks about this, people talk about the moonshot of changing this. Well, nobody had ever been to the moon before, so it was an open territory. It doesn't mean we were going to get there, but there wasn't something to unbuild in order to build something new.
Yeah.
Our challenge, our generation's challenge, is unbuilding this, and figuring out how to do that, developing the will, having the organizational capacity. We've got to figure that out. And institutions, like yours here at Houston Methodist, in particular the DeBakey, Heart and Vascular Center. I mean, your team is incredibly well organized, sophisticated, and so forth, and amongst the groups that others are going to be looking for in terms of how do we lead this, on a local level. I don't think there's going to be a top-down solution that rolls out. Whatever one would feel like we're feeling from legislation today, put upon and so forth. There are going to have to be internal solutions.
Jeff, I think I could sit here and learn from you all day, but at this point I will, you've been talking a long time. Thank you very much for coming for rounds and for spending a few more minutes with us. It's been fantastic.
My pleasure.
I've learned a ton. Thank you.
Thank you so much.